Once I used to grow some wheat in my garden, but whenever I used to eat this wheat, I used to get a headache. So I went to my GP and described the scenario to him, and you know what he told me? He said, it's probably migraine. Migraine. And I tried to take a picture of a wheat farm the other day, but unfortunately it came out too grainy. Hello everybody, Dr. Ryan here. I hope you and your folks are well. Thanks for joining me. I encourage you to subscribe to my channel so that you don't miss any upcoming videos. God bless you. We're talking about celiac disease today, alrighty? So this is the outline of our talk. We're going to address a clinical case just to give us some perspective and context. Then we're going to break down celiac disease 8 ways, talking about introduction, etiologies behind it, looking at patient presentation and the way patients present in terms of signs and symptoms. Then we're going to break down a plausible differential diagnosis, look at diagnostic evaluation in terms of investigative workup. Then treatment and management modalities, prognostication, complications. We're going to close with summarizing our key points, encouraging from scripture. Thank you so much for joining me today, guys. Let's get stuck in. We got a 23-year-old female coming to you, evaluated by a primary care physician for diffuse, crampy abdominal pain, not too comfortable. She reports that she had abdominal pain for the last several years, but is now progressively getting worse and now associated with intermittent diarrhea without flatulence. This does not weaken her at night. Stools do not float and are not hard to flush. She has not noted any worsening with specific foods, but she does have occasional rash on her lower legs. She has lost almost 4 kilograms in the last year. She's otherwise healthy, takes no meds. Which of the following is the most appropriate recommendation for her at this point? Is it A, to increase dietary fiber intake? Is it B, measurement of our beloved anti-endomysial antibodies? C, measurement of 24-hour fecal fat? D, referral to gastroenterologist for a scope? E, trial of lactose-free diet? Let's talk celiac disease, guys. It is also termed gluten-sensitive enteropathy. It is a multifactorial, immune-mediated enteropathy triggered by ingestion of gluten-containing grains, right? Or which grains contain gluten? I'm glad you asked. Wheat, rye, and barley. Wheat, rye, and barley. And it manifests in those who are genetically susceptible. The incidence appears highest in places where wheat represents a significant part of the diet, especially the northern hemisphere countries, England, Ireland, Italy, USA. It is relatively common in the States, affecting about 1 in 150 Americans, so not that uncommon. Looking at etiology, epidemiology, and risk factors, guys, the inflammatory reaction occurs in the epithelial layer and the lamina propria and results in small intestinal villus atrophy with mucosal lesions and lymphocytic and plasma cell infiltration, right? Adaptive immune responses preceded by altered processing of Gliadin protein by interluminal enzymes, changes in intestinal permeability, and activation of innate immune system are responsible. 75% of monozygotic twins are concordant with the disease. Therefore, environmental factors are important in the pathogenesis. Now, at least 95% of those affected are also genotype HLA-DQ2 and HLA-DQ8 positive. However, the concordance rate among HLA identical siblings is 30 to 40%, so it's obviously polygenetic in origin. Increased incidence among kids with immunoglobulin A deficiency, trisomy 21, insulin-dependent diabetes mellitus, which is type 1, and Turner syndrome, and those with dermatitis herpetiformis. That is a classic dermatological lesion associated with celiac disease, dermatitis herpetiformis. Other associated autoimmune disorders include thyroiditis, Sjogren's syndrome, microscopic colitis. Upwards of 8 to 10% of patients will have a first-degree relative who is affected by celiac disease. In kids, the gender ratio is 1:1, but in adults, there is a 2:1, female to male preponderance, right? 6 to 12% of patients with iron deficiency have celiac disease. Today, iron deficiency is the most common presentation of celiac disease in adults. So from a schematic perspective, histologically speaking, what we have here on is this. So looking at the lining of the small intestine, we've got normal villi here on the right, okay? But, so you can see nice crypts between the villi. We see well demarcated. But here, damaged villi in celiac disease, they are kind of flattened, atrophic villi, okay? How do patients present? Many are asymptomatic. Presentation varies in part with age. Children below the age of 2 may present with diarrhea, anorexia, a protuberant abdomen, wasted extremities, failure to thrive, irritability, and vomiting. In adults, presentation may include an atypical GI symptoms in the way of recurrent abdominal pain, bloating, irritable bowel syndrome. Sometimes they may have non-GI symptoms in the way of fatigue, short stature, pubertal delay, infertility. Abnormal labs will show anemia, bone loss, or unexplained elevation in your serum transaminases. Constipation and large stool occur in about 10% of patients. In the teeth, you may have enamel hypoplasia, ataxia, you may have peripheral neuropathy, apatous stomatitis. Kids may present with a constellation of diarrhea, failure to thrive, and irritability. So, celiac disease fits into the world of malabsorption disorders, and these share common characteristics in the way they present, right? So, let's just have a look at some of them. So if many of them with malabsorption disorders have weight loss or malnutrition on the back of anorexia and malabsorption of nutrients, they have diarrhea because of impaired absorption or secretion of water and electrolytes, colonic fluid secretion secondary to unabsorbed dihydroxybile acids, fatty acids. That's in the case of fat malabsorption. Flatus because of bacterial fermentation of unabsorbed carbohydrate. They get glossitis, chelosis, stomatitis because of deficiency of iron, vitamin B12, which is cobalamin, folate, and vitamin A. Abdominal pain because of bowel distension or inflammation and pancreatitis. Bone pain because of calcium, vitamin D malabsorption, protein deficiency, osteoporosis. Tetany and paresthesia because of calcium and magnesium malabsorption. Weakness because of anemia or because of depletion of certain electrolytes, especially the kingpin potassium. Azotemia and hypotension on account of fluid and electrolyte depletion. Amenorrhea and decreased libido because of protein depletion, decreased calories, secondary hypopituitarism. Anemia on account of impaired absorption of iron, folate, and cobalamin. Bleeding because of vitamin K malabsorption and hypoprothrombonemia. Night blindness is erythema, the poster child for that is vitamin A malabsorption. Peripheral neuropathy because of cobalamin and thiamine deficiency, and dermatitis because of deficiency of vitamin A, zinc, and essential fatty acid. Guys, what looks like and smells like celiac disease but is not celiac disease? Let's look at a differential. So tropical spree, cystic fibrosis, right? Milk protein enteropathy, giardiasis, chronic pancreatitis, immunodeficiency, A-beta lipoproteinemia, lactose intolerance, IBS, which is irritable bowel syndrome, Whipple disease, small bowel bacterial overgrowth, eosinophilic gastroenteritis, Crohn's disease, intestinal lymphoma, all may mimic celiac disease. Now, how do we work up patients in whom we suspect may have celiac disease? Good idea to do antibodies, right? So screening antibody testing for anti-tissue transglutaminase immunoglobulin A is recommended and has a sensitivity and specificity of 95%. Excellent. The other ones you can do is anti-endomysial IgA is equivalent or mildly superior to tissue transglutaminase, but it is expensive and relies on operator interpretation, which is operator dependent. Anti-gliadin antibodies have poor sensitivity and specificity. So the kingpins in terms of antibodies, anti-transglutaminase and anti-endomysial. HLA testing in terms of HLA DQ2, DQ8 are positive, like we said, in about 95% of folks and 30% of unaffected individuals, and is therefore useful in ruling out the disease, right? If rule out, it has good specificity, right? Small intestinal biopsy is a gold standard for, sorry, I beg your pardon, if you're ruling out, it has good sensitivity, right? Small intestinal biopsy is the gold standard for diagnosis. It reveals villous atrophy with crypt hyperplasia and increased intraepithelial lymphocytes. Disease is typically most severe in the proximal small bowels, looking at the duodenum, and can be reached endoscopically. Multiple biopsies up to 6 to 8 are recommended as the disease may be patchy. Okay, repeat biopsies on a gluten-free diet are generally recommended to document histological improvement. A trial of gluten-free diet without diagnostic biopsy is not recommended. You want to screen for concomitant nutritional deficiencies, including iron deficiency anemia, so do your iron studies, do a folate level, vitamin B12, which will manifest with anemia, glossitis, peripheral neuropathy. Vitamin K deficiency will masquerade with coagulopathy and purpura. Vitamin D deficiency with hypocalcemia, tetany, osteoporosis. Vitamin A deficiency with xerophthalmia, night blindness. So this is your stains, hematoxylin and eosin stains mostly, looking at small bowel biopsies, right? And we can appreciate here in image A, this is a normal, healthy person. Beautiful crypts of Lieberkühn here, well demarcated, okay, looking really good. In B, we have untreated celiac disease. Okay, so we can see there's hardly any crypts, villous atrophy. Thank you so much. In C, we have treated celiac disease, where you see those crypts forming and the villi a bit better demarcated than in image B. And image D, we see intestinal lymph ectasia. Okay, here we're looking at barium contrast small intestinal radiological examination, right? And this is a normal person. This is what we expect to see in the pattern of barium contrast administration in a person who's normal, right? But in B, we can see celiac disease, right? So you can see that is not that well demarcated. All right, C is diverticulosis and D is Crohn's disease. Guys, how we get celiac disease? So once the diagnosis is made by biopsy, the patient should be placed on lifelong gluten-free diet. So wheat, barley, and rye are no-go areas, dietarily speaking, if that's a word. So advise them not to eat gluten-containing products. Oats do not contain gluten, although the milling process may contain some contamination or may result in contamination. A trained dietitian and support groups would assist in terms of initiating the appropriate diet. Vitamin and mineral supplementation to replace deficiencies. Patients in celiac crisis, which speaks to severe malnutrition, often require volume repletion and correction of electrolyte imbalances. Steroids may be helpful as well. Future therapy may include enzyme supplementation with bacterial endopeptidases to destroy the antigenic epitopes. Transgenic agriculture is working on producing gluten-free wheat, so those are coming attractions. Family members may be screened or should be screened for celiac disease once a proband has been identified. Patients generally respond to a gluten-free diet. Normalization of serology and histology generally takes about 6 to 12 months. Adolescent patients may find it difficult to comply with the dietary restrictions, right? Because lots of the food that we eat contain gluten. Failure to avoid gluten may result in growth failure, delayed puberty, small bowel lymphoma, which is probably the most dreaded complication, small bowel adenocarcinoma, diabetes, thyroid disease. The mortality rate exceeds that in the general population by at least 2 times, mainly due to malignancies, and we spoke about non-Hodgkin lymphoma and GI cancers, including oropharyngeal esophageal squamous cancer, small intestinal, colorectal, and hepatocellular. There is an apparent decrease in the risk of breast cancer, which has been observed. Gluten-free diet may be protective against malignant disease. So guys, the key points I want to take home is celiac disease is an immunologically mediated disease in genetically susceptible people caused by intolerance to gluten, resulting in mucosal inflammation and villus atrophy, which causes malabsorption. Symptoms usually include diarrhea, abdominal discomfort. Diagnosis is by small bowel biopsy, showing your characteristic, though not pathognomonic, changes of villus atrophy that resolve with a strict gluten-free diet. Alrighty, guys, so coming back to our clinical case, we had a young female who has what may be celiac disease. She got crampy abdominal pain for a long time now with intermittent diarrhea without flatulence, doesn't wake up at night. Stools are not hard or difficult to flush. No association with specific foods, although she probably has dermatitis piriformis on her legs. She has lost 4 kgs in the past years, otherwise healthy, no other meds. What you gonna do? What you gonna do? What you gonna do when they come for you? Measurement of anti-endomysial antibody indeed. So the patient's symptoms may be consistent with celiac disease. The widespread availability of antibodies to gliadin, endomysium, and tissue transglutaminase can be easily measured in peripheral blood. Anti-endomysial antibody is beautiful, has 90 through 95% sensitivity and equal specificity, making it a very reasonable first test in persons on whom you suspect may have celiac disease on account of their symptoms. Okay, my friends, let's just talk about the Bible. The book of Jeremiah 32 verse 27 says, "Behold, I am the Lord, the God of all flesh. Is anything too hard for me? Indeed, is anything too hard for the God that we serve?" The Bible says, what is impossible with man is possible with God. He is great and mighty and sovereign and holy, and there is nothing impossible for him. So that begs the question, why do we faint in adversity? Why are we so troubled and anxious? We just commit the situation to God. And when you are faithful, the Lord always undertakes. Be encouraged, my friend. Okay, here are my references. If you enjoyed this video, I strongly encourage you to subscribe to my channel, like and share this video. Thank you so much. I really appreciate it. You can catch me on Facebook. Just search for Internal Medicine, Algorithms, and Mnemonics. I'm also on TikTok and Instagram as well. We've got some exciting topics coming up. We've got Hodgkin's lymphoma, right? And we've got a topic talk on nephrotic syndrome. Very topical internal medicine subjects. God bless you. Have yourself a wonderful day. I'll see you soon.